Continuing education credits for physicians and other healthcare professionals is provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information.
The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed on this podcast are solely those of the host.
Welcome back to the Cribsiders. I'm Chris the Chew Man Chew, and I'm joined by my amazing co-host, Sam Mazer. Say hi, bud.
Hey, everybody.
And our amazing producer, Rachel Holloway.
Hello.
Tonight, we are joined by our guest, Dr. David Vitale, to discuss pediatric pancreatitis. We actually have two parts. But first, Sam's going to remind the audience about what the show is about.
Oh, thanks, Chris. So we are the Pediatric Medicine Podcast. We interview leading experts in the field to bring you clinical pearls, practice-changing knowledge, and answer lingering questions about core topics in pediatric medicine.
Today we have a fantastic conversation with our guest, Dr. Vitale. He is a pediatric gastroenterologist and director of the Interventional Endoscopy Center at Cincinnati Children's Hospital. Within the Cincinnati Children's Interventional Endoscopy Center, Dr. Vitale performs ERCP, EUS, double balloon enteroscopy, amongst other advanced procedures with a national and international referral base. He's a member of the Cincinnati Children's Pancreas Care Center, where he cares for children with pancreatitis and other pancreatic diseases. He also runs a multi-center national database to investigate the safety and utility of EUS in children. And then, amongst all of this, his other research endeavors also includes investigation of EUS findings in children with acute and recurrent chronic pancreatitis and the evaluation of risk factors and risk mitigation of post-ERCP pancreatitis. Wow, he does a lot. But in this two-part series, he, in the first episode, will tell us about the etiologies, presentation, and treatments of acute pancreatitis. And then in our part 2 episode, he will talk about acute, recurrent, and chronic pancreatitis. It's a lot of pancreatitis, but we are super excited to get into it.
Yeah, our listeners better not bellyache about not getting enough pancreatitis if they ingest all parts 1 and 2. I screwed that one up. You guys enjoy that. Make something out of that. There you go. It's been a long day.
All right, let's get to it.
All right, welcome back to the show. I have Dr. David Vitale. First, Dr. Vitale, since we're an informal group, is it okay if we call you by your first name? Fantastic. All right, David. So we're just going to start off with some softball questions just to warm up. Could you tell our audience a little bit about yourself? What you do, and maybe a little something outside of medicine that you like to do.
Sure. Yeah. So I'm a pediatric endoscopist and pancreatologist. I focus on clinical research, clinical care of pediatric patients with issues that need advanced endoscopic procedures, and many of those patients have pancreatitis. And so that's what I really focus on. I also have a wonderful wife. She fundraises for our hospital. We've been married for 14 years. I'm a father of 2 boys, 4 and 6. So my house is like a WWE zone most of the time right now. I'm a dog dad. I love to cook and ski. So those are kind of some of the things I do outside the hospital.
Oh, nice. And did you have fun skiing anywhere recently?
Yeah, Park City. So I
wow.
have gone, last few years, I've taken my family out to Park City. My older son now has been skiing there for 2 years, and he's really starting to get the hang of it. So it's a lot of fun.
Wait, the 6-year-old?
Nice.
The 6-year-old.
Wow.
Yeah, he started ski school when he was 4 out there, and now we've been the last couple of years. And you wouldn't know it, but just close by to Cincinnati, there's about 45 minutes away, we've got a place that we can go during the winter on the weekends sometimes too.
I was going to say, I've only ever known Perfect North. And
that's it. Perfect North. Yeah.
And I've only ever gone down the really small hills.
Yeah, it takes about 15 to 30 seconds to get down those hills.
Yep.
But, at least it's something.
That's true. Nice. It's a good place to train.
There you go. There's the Cincinnati Rex for everybody. The ski resort in Cincinnati.
Exactly.
This is what we're getting the good stuff
Cincinnati
here.
Chili. Just go skiing.
Exactly. Yeah. No, forget about Park City. Really, that's what it comes down to.
Well, if you can ski and get Cincinnati chili together, I think that's a dream come true.
There you go. Not at the same time. I do not recommend.
Amazing. You mind if I take the next question?
Go for it, man.
All right. I'm just going to ask I'm going to ask the advice question because I do love that one. So what's the best advice you've ever received as a learner or as a teacher in your career?
Yeah, so I think a couple of things that I've gotten over the years. So one of the things, when I was a first-year medical student, Dr. Temis, who's one of the pulmonary surgeons at University of Louisville, where I went to medical school, he gave us the advice. We were doing sort of mock patient interviews in first year of medical school, and he stopped everybody in the middle of these mock interviews, and he said, every single one of you is talking too soon to the patient. And he said, listen to the patient. They will give you the diagnosis. And so one of the things I try to do now when I go into rooms is I really, ask an open-ended question tell the patient, I want to hear your story. What brought you here? And what are your specific questions we can help you with? And I try as best as I can, which is very difficult because I like to talk. I try as hard as I can to not say anything for as long as possible to let the patient and the family talk until they have a pause and a question. So I think that was really the best advice I got as a learner early on in my medical career.
That's a fantastic one. I've got a similar story, except it comes out different. I was a first year med student. And I was doing an interview with a standardized patient in front of a small group, and I completely blanked and I had no idea what to ask next, but it seemed like a really long pause. And then all of a sudden the standardized patient started giving this other history. And then after doing the debrief, the other students were like, oh, Chris, you did such a great job giving the patient enough time to talk. And I was like, I was like, yeah, totally. I really meant to do that.
That's hilarious. Yeah, one time I think it was on my psych rotation, they were like, you can just let the patient sit in the silence, and that might actually give you more than you could have gotten by asking a ton of questions. So all comes down to the same thing. Very interesting. All right, let's see. I want to ask, what is a book that you think every physician should read? Or conversely, what is your pick of the week? What is something that you've been reading, listening to, watching recently?
Yeah, I think I'm going with the book question. And this is so I read a book, I think actually when I first got into medical school, somebody gave me this book, and I cannot remember who it was, but it's called How Doctors Think, and it's by Jerome Groopin. And I'm not sure if any of you have read this. It's not necessarily aimed at physicians. It's almost aimed more at patients, but it's a really great book that is written by a physician that has a good focus on doctor-patient relationships and interactions, which I think is probably my favorite part of being a physician, is establishing relationships. Now that I've been in, taking care of pediatric patients for more than a couple of years, I've seen some patients growing up, and really had great relationships with the patients and their families. But it's a great book to get you a little bit more in depth on how those doctor-patient relationships are established and how things look from both the doctor side of things and the patient side. And so I encourage everybody to read that one. It's a really interesting read.
That's a great suggestion. I've had definitely other people suggest that to me. So I'm definitely going to have to put that on my big stack of books on queue. So thank you for that.
Sure.
Actually, before we move on, I think Rachel and I have the same pick of the week, right? What's your pick of the week, Rachel?
It's allergy medicines. And the reason that it's my pick of the week is because I had a nice allergic reaction to a cat at my hairdresser's about 2 hours prior to recording this. So I came out of it with a very hoarse voice. So I'm glad that it's improved after some allergy medication.
I think it's been ragweed season over here in the Ohio River Valley, so I've been having lots of rough times all this week. So yes, allergy medicines are high on my pick of the week as well.
If you're in healthcare, you've probably heard of figs. And if you haven't tried them yet, let me just say, total game changer. These scrubs are made specifically for awesome humans, designed to handle long shifts, constant movement, and everything the job throws at you, all so you can perform at your best. I can't walk into a clinic, hospital, or emergency room without seeing healthcare providers in fig scrubs. As a hospitalist, I wear figs and I can't say enough good things about how comfortable they are. The material is extra soft and form-fitting, but also tough as can be. It's not just me that wears figs either. If you've been watching a very popular ER drama on TV these days, they wear fig scrubs too. So what is figs all about? They are engineered for comfort and performance. Fig scrubs are lightweight, breathable, stretchy, and antimicrobial, built to keep up with long shifts, back-to-back patients, and whatever the day throws at you. They are modern, tailored fit without sacrificing function at all. These aren't your boxy, one-size-fits-all scrubs. They're designed with precision and come in flattering styles and colors, with smart pockets, secure zippers, and thoughtful details so you can perform at your best. Lastly, it's more than scrubs. It's a movement. Figs is changing the perception of medical apparel, and through their Threads for Threads initiative, they're outfitting healthcare professionals around the world. So wherever you wear figs, in the ER, on rounds at the clinic, or even just running errands after a shift, make it count. And next week is Nurses Week. And in appreciation for these awesome humans, Figs has an exclusive 20% off everything from May 1st through the 7th. That's wearfigs.com to get 20% off May 1st through May 7th. Happy Nurses Week.
All right. Sam, are you good?
I'm great. Let's get going into this case. We got a lot to talk about. We got acute pancreatitis, maybe. We got something else, maybe. I'm just going to kind of tease this a little bit. Rachel, why don't you get us started?
Not acute pancreatitis.
Use your imagination. All right, case 1 from Cash Like Children's. So Amy Lace is a 16-year-old female who presents to Cash Like Children's with a chief complaint of abdominal pain, which started 1 day ago. She describes her pain as constant and severe, with worsening after meals and when laying down. It's improved by leaning forward, and it radiates to her back. She's also had severe nausea, vomiting, chills, and an inability to tolerate PO intake. She has had several episodes of sharp right upper quadrant abdominal pain associated with meals in the past, but these episodes have never lasted longer than a few hours. Her vitals are notable for a BMI of 30, so 98 weight percentile, tachycardia, tachypnea, but a stable blood pressure, and then her exam shows epigastric abdominal pain with voluntary girding. So I know that the title of this episode is probably a spoiler, but Dr. Vitale, what diagnosis are you most concerned for?
Sure. So exactly. There's a little bit of a spoiler here, but to be honest, probably what jumps out at me about this case more than pancreatitis is my concern for gallstones. So, there are plenty of patients who come in who are 16 years old with this exact type of history and have cholecystitis, or they have choledocholithiasis, meaning common bile duct stones, which could be obstructive and causing cholangitis. This patient is having chills. I don't think we heard about any fevers or vital signs, other than her BMI and tachycardia, tachypnea. But if this patient had fevers, we could be concerned about cholangitis as well, cholecystitis. And so really, I'm more in the world of worrying about gallstones. And then secondary to that, if you have gallstones and if they are intermittently entering into the bile duct, then we're always worried about pancreatitis. We see that more frequently in children now than we ever have in history. And if you look at some literature out there, looking at not even only in the United States, but worldwide, we know that gallstone incidence is increasing along with obesity in pediatric patients.
Now, one question I have is, our patient here is a 16-year-old. In terms of etiologies for pancreatitis, does this change with, say, if it was an even younger patient with a similar presentation? And that's my first question.
Yeah, so my differential doesn't change a lot based on this history. If it's somebody that's in the obese category, we see children that are quite young sometimes even with gallstones. It's surprising, but sometimes I'll be doing procedures in patients that are 6 and 7 years old or even younger with gallstones. The most frequent etiology of pancreatitis, if we're talking about pancreatitis in this age group, is drug-induced pancreatitis. So anyone in the pediatric age group, really, that's the most frequent presentation. And there's some other things if a patient is more below age 5 that we might consider more frequently. Those patients have more congenital aspects that may be affecting things like a choledochal cyst. Those patients with choledochal cyst can present with gallstone disease, anomalous pancreaticobiliary junction. And sometimes we see it in patients who have been, for one reason or another, MPO for a period of time. So say it's a patient with a cardiac problem who's been in the ICU for a while and on TPN. Those patients tend to get some biliary stasis and can get gallstones as well and potentially lead to pancreatitis too.
So I think we're the good news is we're really jumping into this, but we are getting a little bit ahead of ourselves in the sense of our definitions and whatnot. So I thought we're talking about sounds like hepatobiliary pancreatic system. These are the things you're most concerned about when you're seeing this patient. We definitely want to ask you about pancreatitis. So maybe we can start with some definitions. So how do you define pancreatitis and more about the physiology behind it?
Sure. So when we talk about pancreatitis from a clinical perspective, we're looking at having in pediatric patients 2 of 3 criteria. So, the primary criteria to diagnose acute pancreatitis is abdominal pain of pancreatic origin or suspected pancreatic origin. I think most of us are familiar with that. Patients have epigastric pain, which can radiate to the back. It does not always. We sometimes have patients present with only back pain, some other type of pain, especially younger type of patients. The other criteria are having an amylase or lipase greater than 3 times the upper limit of normal. Very important to know what your lab or the lab that you have received the labs from, what their upper limit of normal is, because it varies from place to place and it can vary quite a lot. And then the last possible criteria is imaging finding of pancreatitis. So if you have 2 of those 3 factors, we can make the diagnosis of pancreatitis. And really the pathophysiology of this is based on premature activation of an enzyme called trypsinogen. And that prematurely activates in the pancreas for one reason or another, and that causes local pancreatic activation of inflammatory cascade there in pancreatitis.
Now, so these diagnostic criteria, are these the INSPIRE criteria from NASPGHAN?
Correct. So the INSPIRE criteria, INSPIRE is actually a group that is dedicated to pediatric pancreatitis, and they have established these criteria. And NASPGHAN is our National Pediatric Gastroenterology Society. And those criteria are both endorsed by both of those groups.
If you really think this kid might have pancreatitis, and like you say, looking at these criteria, you're looking at especially these this serum amylase or lipase. Can those change over time? Like, can you get it too early and consider rechecking later, or is this something that will happen pretty soon after someone? And if they're symptomatic, you would catch that while you're doing a screening.
Yeah, absolutely. That's a great question. So typically, soon after the symptoms start, or as soon as the symptoms start, you're going to start to see those levels elevated. Now, that being said, sometimes we might get a value that's very early on in the presentation, and it's not quite 3 times the upper limit of normal. And that's when, we would potentially trend the lab if they're having specific symptoms that we're worried are pancreatitis type of symptoms. The other thing that I would mention is that a lot of patients present at different time courses in their pain. So, one patient might be having abdominal pain on and off for a couple of days and then come into the emergency department. Another patient may have sudden severe pain and come in, within a couple of hours of their presenting symptoms. So we always keep that in mind, that we're really thinking about time from onset of the pancreatitis is really time from onset of the symptoms rather than when they presented to the hospital.
So jump into this case, I think that was a good setup with kind of some of the labs and things that you'd get. Just seeing this case right off the bat, without even saying we're talking about pancreatitis specifically, what workup are you ordering for this patient?
Sure. So I think, we're going to get a basic set of labs, which are going to include a CBC with a differential, the patient's having chills, et cetera. We're going to get liver enzymes, and we're going to make sure that we get a total and direct bilirubin with that. So, if you order your complete metabolic panel, a lot of places that just comes with a total bilirubin. So you really want to make sure that we're getting a total and a direct bilirubin here. We want to get an amylase and lipase. Really, those are the main labs that are going to help us make a diagnosis in this patient.
Awesome. And just one more question about the lab piece before we jump on to any imaging, which I'm sure everyone who's listening is trying to, kind of chopping at the bit to hear. Amylase and lipase. Sensitivity and specificity between each of them, do we actually need both of them? If one is positive and the other one's negative, do we care? Would you mind walking us through those things? Because I feel like I've always trended towards just getting a lipase these days.
Yeah, so lipase is certainly more specific, and they're both fairly sensitive markers. And, relative to serum amylase, which is sometimes a little more time dependent, serum lipase elevations are less time dependent because it peaks a little bit later and has a longer duration of elevation, whereas serum amylase peaks a lot more rapidly and then will go down a little bit more quickly. Now, that being said, I like to get both of them because, especially early on in the presentation, you may see a high amylase, whereas the lipase is sort of lagging behind a little bit because its peak is not quite as quick. Yeah.
Awesome. So if we're talking about when you're always asking, hey, did your symptoms start 2 hours ago or 3 days ago? That probably also helps us if we're going to see, like if amylase is high, but lipase isn't high for the patient that started an hour ago, that might give us something versus if it started 3 days ago, our lipase is more specific.
Yeah.
Okay.
And you wouldn't be terribly wrong to get only lipase in that sort of setting because we do know the lipase is more sensitive and more specific for acute pancreatitis.
Gotcha.
Now, you suggested a couple labs that were not part of that diagnostic criteria we discussed before, like the CBC and the Billy. Can you explain how we might interpret some of the results we get back from those?
Sure, and I think that's very specific to this case, and that is because we're worried about gallstones in this patient. Somebody coming in with this on and off pain after meals that's been going on for quite some time, and then all of a sudden it gets bad and doesn't go away. That to me is biliary colic type of pain. And this patient now with, the high BMI, tachycardia, tachypnea, I think some of the differential I mentioned earlier, cholecystitis, common bile duct stone, cholangitis, etc. That's where the CBC and the liver enzymes are going to help me make a determination how worried I am about a stone obstructing the common bile duct or there being an infectious process going on.
And then as far as the CBC goes, we looking for like a leukocytosis or what are you looking for in that?
Yeah, so typically I'm looking for, what do things look like from a standpoint of the white count, just as you mentioned, a leukocytosis. Sometimes we can get an idea of where things are from a fluid standpoint. So if this patient does end up having pancreatitis, and it has a very high hematocrit, the patient may be quite, concentrated. One thing I didn't mention in this, which I think in a patient, that's sick, getting a metabolic, basic metabolic panel would probably be a reasonable thing too, to see if there's some type of renal injury going on and see what their blood urea nitrogen is in relationship to their creatinine, also looking for that hydration status. And we won't get into it just now, but some of those lab markers can tell us whether we would potentially predict this patient, if they do have pancreatitis, is going to have a more severe course or a more mild course of pancreatitis.
We'll definitely get into that a little bit later in the case. Before we jump ahead, I want to talk about imaging. I've heard different things. There's ultrasounds, there's CTs, there's MRIs. What do you normally go for as first choice of imaging? And what are the sensitivities, specificities of the different modalities?
Yeah, so for a first-time acute pancreatitis patient that comes in, or a patient where we're concerned about gallstones or stones in the common bile duct, transabdominal ultrasound is really the first choice, especially in a pediatric patient. It's fairly easy to get in pediatric patients, whether they're small or large. It doesn't require any kind of sedation for that to happen. And the nice thing about it is that when you pick things up on it, it's great, when you're able to see things. Now, that being said, a lot of times, and some of you may have some experience with this, we'll get a transabdominal ultrasound. Pancreas cannot be seen due to overlying bile gas. The bile duct is not well seen. So there are times where we're not able to get really good sensitive images on a transabdominal ultrasound. If we're able to see things well with the ultrasound, it's great. The findings of acute pancreatitis can be seen in up to about 50% of the time with a transabdominal ultrasound. And if you can see the pancreas relatively well, then you're really done with your imaging. If you can see the pancreas and the bile duct in this patient and confidently, the radiologist is able to tell you if there's pancreatitis and or stones in the bile duct or gallbladder. And
if we're not getting good ultrasound images, like what would force you to be more aggressive of saying we need to put the kid under sedation, we need to get a CT or an MRI? Or
Yeah, and typically CT scan, even young kids, we're not needing to do sedation these days. An MRI or an MRCP is a different story, especially in younger kids. So typically I think the next step for us, dependent on what we're really concerned about with those lab results, is probably going to be either a CT or an MRI. If we're really worried about there being a stone in the common bile duct, and we're worried about the bile duct and it's not well seen on an ultrasound, an MRI is really going to be mostly, the more sensitive way to pick up what may be going on in the bile duct. If we're really just wanting to look at the pancreas and we're worried about acute pancreatitis and the liver numbers have come back normal, we're going to think more about getting a CT scan because it's a bit faster. You're not going to need to sedate a patient if they're young, and it's quite sensitive for picking up pancreatitis. But really, when we talk about the sensitivity of it, the CT findings of acute pancreatitis are present in pediatric patients up to 75% of the time in acute pancreatitis, and MRI is relatively similar.
Now, you said another diagnostic modality that sounded like MRI, but could you explain a little bit what MRCP is and
Sure.
why would one choose an MRCP?
Yeah, so when we say MRCP, it's really just a type of MRI, and it's a magnetic resonance cholangiopancreatography. And all that means is that we are lighting up and focusing on the bile duct and the pancreas duct when we get these images. And with that focus, we're able to, hopefully with a much higher sensitivity than ultrasound, identify whether there are stones in the common bile duct. We know that MRI is the most sensitive, non-invasive imaging modality that can tell us about the stones there. Ultrasound actually turns out, right upper quadrant ultrasound is probably more sensitive than MRI for picking up stones in the gallbladder.
So when people say MRI, do they normally mean MRCP, or is there a different type of MRI scan that you could potentially do outside of MRCP for this type of
No,
patient?
you could do an MRI without doing the cholangiopancreatography. It basically sequences. And this gets a little convoluted because if you look in the literature, there's a lot of variability about the sensitivity of MRI in picking up on pancreatitis, both acute and chronic changes in the pancreas. And that's likely because the sequences that are used vary from institution to institution. And so when we talk about MRI, if we exclude doing the CP part of that, the cholangiopancreatography, really all we're doing is magnetic resonance to look at the stomach, to look at the abdomen, to look at the pelvis, wherever you need to look with that, and either giving IV contrast or not, and not doing specific sequences to look at the ducts of the pancreas and the bile duct.
So it sounds like, to summarize, from our patient, because I think we're just getting ready to give you some of these lab results. We have classically the defined pancreatitis. We have 2 out of the 3 criteria. We have either classic abdominal pain, elevated amylase lipase 3 times the upper limit of normal, or the abdominal imaging, which we just discussed. For this patient, you would probably start with a CBC-CMP, make sure we have our bili differentiation, lipase and amylase, and then we'd probably go with the ultrasound. If we can't see anything on the ultrasound, then we start asking ourselves, hey, should we do CT, MRI? But we can get to that being specific and talking with our radiologist. So we got all those tests. Let's say we got all those tests, and Rachel can kind of read us through some of the results and see where we're at.
Yes, I have all of the results except the bilirubins, which are pending in the lab right now.
Nice.
But,
Nice.
Of course they are.
Yeah.
But all right. So pertinent workup includes a leukocytosis of 18, an elevated ALT of 170, an elevated AST of 55, and an elevated serum lipase of 380. Transabdominal ultrasound shows a hypoechoic pancreas with biliary sludge. No gallstones are visualized, but we are able to see the gallbladder.
So, yeah, I think our next question is kind of saying, did we make a diagnosis of acute pancreatitis? And I think that's our first question to ask you here.
Yeah, I think based on, now this gets back to that, what's the upper limit of normal in our lab?
Right. Let's say 100.
So let's say the upper limit of normal is 50.
Yeah,
right?
perfect.
So if the upper limit of normal is 50, then yes, this patient has classic pancreatitis type abdominal pain. They have a lipase that's more than 3 times the upper limit of normal. We could be done there and say they have pancreatitis. Now, the transabdominal ultrasound also shows us some echogenic changes, meaning or hypoechogenic changes in the pancreas, which can be consistent with pancreatitis. It also shows us some biliary sludge, which I'm assuming is probably in the gallbladder, some sludge, and that's really helpful for us to know.
Yes. I think
no
I said
big stones visualized.
I said no. I said we did not see the gallbladder, but that would be contradictory to the fact that we saw biliary sludge. So we did see the gallbladder, just to redact my former statement.
Yeah.
Can you explain what biliary sludge is? Because when I was a med student, and probably for a little bit longer than that, I didn't fully understand what biliary sludge was. And I would look at it and be like, no gallstones. That's great. Yeah. What does it mean?
It's I mean, the way that I describe it to patients is it's like biliary sand. It's more stones that haven't quite formed yet, and so small little bits of either stones that are on their way to forming or have crushed themselves up a little bit, and it absolutely is important for us to know about, because when those little bits of sludge come out of the gallbladder, through the bile duct and into the intestine, they can pass through the ampulla and temporarily obstruct the pancreas duct, and that can cause pancreatitis by itself. The other important thing to know about it is that even in patients that don't have pancreatitis, if they have sludge in their gallbladder, it absolutely can cause symptoms.
EZ Resus is your ultimate support to take care of your sickest patients during resuscitation. Whether you are taking care of a newborn during a precipitous delivery, a septic child requiring endotracheal intubation, or a seizing teenager, this offline app has drug dosing, equipment size calculation, treatment algorithms, all available in under 3 clicks. This gives you rapid access to life-saving critical info in a user-friendly interface, taking care of the logistics of resuscitation so you can take care of what really matters, your patient. For those who do not work with critically ill patients, the app also has calculated doses of the most used PO and IV medications, including antibiotics and analgesia. Also, you can find critical first steps for basic and advanced life support, which could be useful for anyone, anywhere. Finally, for those in our audience who also work with adult patients, there is a complete adult section with the same features as in pediatrics, including weight-adjusted dosing for heavier patients, treatment algorithms, and more. So someday you'll need to act outside of your comfort zone, and with EZ Resus, you will be ready. So Cribsiders listeners, here are the benefits. They're made for all clinicians and all patients with a user-friendly interface, 100% offline content and available on any device. Drug dosing, treatment algorithms, and equipment size dynamically calculated based on patient characteristics. Multiple alerts and content adjusted to age and weight to ensure safety. Content entered and reviewed by over 30 healthcare professionals, and available for institutional access, including an online version, group pricing, customizable content, and exclusive features. So, listeners of the Cribsiders get access to a 2-month free trial, letting them use 100% of the features of the app. So download EZ Resus on the App Store or Google Play Store, create your account, use code Cribsiders, that's code Cribsiders, and then start using EZ Resus. And for more information, visit www.ezresus.com/Cribsiders. That's www.ezresus.com/Cribsiders. And lastly, for learners, that's students and residents, the app is completely free for the first 2 years. So it sounds like we made this diagnosis of acute pancreatitis now. Usually what we always want to try to figure out with most of our patients is you have a disease process, and now why did you have the disease process? So what kind of is your next step to figure out why they have this issue, and is there any kind of workup associated with that?
Yeah, so in a patient like this where we see sludge in the gallbladder, we have elevated liver enzymes, our bilirubin is still pending. The diagnosis that we're going to make is gallstone pancreatitis, with common things being common. There are other etaologies of acute pancreatitis in children and adolescents, but in this patient, I think, we're going to clearly call this gallstone pancreatitis without any other workup really necessary. The biggest question I'm going to have next is, what is that bilirubin? Because it's going to help me decide, do I really think that there's a bit of sludge or a stone that hasn't been seen on the ultrasound that's impacted in the bile duct and is not moving? Or was this a case where a little bit of stone or sludge passed through the ampulla, temporarily obstructed the pancreas duct, and is gone now and not ongoing obstruction?
And if you had, say there wasn't any biliary sludge, say your ultrasound was normal, but you still had like an elevated ALT, and we'll say we have a bili of like 3.1, are those enough to give you kind of diagnoses from that standpoint? Or are you starting to think about other things?
I mean, I think that really helps a lot with the elevated bilirubin. If you include that elevated bilirubin and with elevated liver enzymes before I even get an abdominal ultrasound, if my lipase is high and I have that scenario, the highest on my differential is going to be gallstone pancreatitis for sure. And sometimes we have, actually a lot of the time, we have cases where we do a transabdominal ultrasound in that exact same scenario, and the ultrasound doesn't see the bile duct well,
right,
or doesn't find anything in the gallbladder. And there are a few other things that can cause there to be, obstruction in the bile duct with pancreatitis, including autoimmune pancreatitis. But common things being common in this obese patient, we would really think more along the lines of gallstone pancreatitis.
And maybe this is a good opportunity to kind of talk about that differential diagnosis. I remember in adult medicine, from back in medical school, there was this get smash mnemonic. So when we think of kids, and let's start with the teenager, let's start with the 16-year-old, kind of what are the other things other than obstructive gallstone pancreatitis that we should be thinking about?
Sure. So for any patient that comes in with pancreatitis, when we look at acute pancreatitis etiology in pediatric patients, the number one cause is drug-induced. So, that actually can occur in about 25% of these presentations. There may be patients that have some viral or systemic or metabolic other issues going on, and that's in about 10% of patients. Biliary or gallstone pancreatitis is probably second to drug-induced. And then we have a pretty high rate of idiopathic acute pancreatitis in patients, in pediatric patients. Up to about 40% of those have uncertain etiology.
Do genetics play a role in pancreatitis?
Absolutely. They play a huge role in pancreatitis, but they are really more in patients that have acute recurrent or chronic pancreatitis. When we look at our patients, just every single comer that comes with acute pancreatitis, a genetic risk factor is present in maybe about 5% of those patients. But it's important to know that 70 to 75% of patients that come in with acute pancreatitis are going to have one episode and never have another episode of pancreatitis again. About 30% of patients will go on to develop acute recurrent or chronic pancreatitis.
So you mentioned something about autoimmune diseases. Can you talk a little bit more about that? Which autoimmune disease would be worried about, and how are they affecting the pancreas?
Yeah, so really the disease we worry about is autoimmune pancreatitis, and it's an entity in and of itself. There are two types, type 1 and type 2 autoimmune pancreatitis, and being that we have a whole panel of med-peds docs here, I don't think we mentioned that earlier. All four of us are med-peds, which is, I'm very happy about that. That's awesome. The thing to know about the types of autoimmune pancreatitis is that type 1 is present in about 80% of adults that have autoimmune pancreatitis. In pediatrics, it's present in about 20%. So a big difference there. And type 1 is, and maybe this sort of crosses over in some other realms, is IgG4 mediated autoimmune disease, immunoglobulin 4 mediated autoimmune disease, which can affect many other organs than just the pancreas. But when we see this in children, more frequently it's type 2. And type 2 autoimmune pancreatitis is actually sometimes more associated with autoimmune hepatitis, associated with Crohn's disease or ulcerative colitis. Not always, but there are some associations there. Or it could be standalone autoimmune pancreatitis where the patient doesn't have other autoimmune disease.
So if you're suspecting autoimmune diseases, what is this a point where you would send some certain specific autoimmune labs, or would you wait until you finish a full workup to try to rule out like the most common things, which are sort of some of the biliary results?
Yeah, so in this patient specifically, I don't think we're that worried about an autoimmune pancreatitis based on the presentation. If there was another patient where we were, that diagnosis is extremely convoluted to make and difficult, just based on the rarity of it. And we really, to be quite honest, as a group of pediatric gastroenterologists and pancreatologists, haven't come up with a great criteria to make that diagnosis. And we really rely on cross-sectional imaging quite a lot for it. So I think the the main thing that we would potentially get in that scenario would be a CT scan or an MRI if that was really high on our differential. Now, we can get also immunoglobulin 4 levels, but again, that's present in a pretty low percentage of pediatric autoimmune pancreatitis. When I get a patient that comes in with their first episode of pancreatitis, one of the things I typically will get is an IgG4 because it's cheap, it's easy to do, and we make sure that there's no autoimmune component if we're still thinking about what is this differential. And one lab I think we didn't mention in this patient with gallstone pancreatitis that's really important in acute pancreatitis are triglycerides, because again, it's a cheap, easy thing to get. It is a cause of pancreatitis, even in the pediatric population. So we want to make sure that we get that level in anybody that comes in with acute pancreatitis.
If you're concerned for autoimmune causes of pancreatitis, would you also look for other associated autoimmune diseases in that particular patient? Like sometimes, you can see several different autoimmune conditions like diabetes and other conditions in one patient or in several family members as well. Would you see that in the case of autoimmune pancreatitis?
Not always. And very interestingly, we sometimes will follow these patients that present with autoimmune pancreatitis, and 2 years later, they develop Crohn's disease, or a year later, they develop autoimmune hepatitis. So sometimes autoimmune pancreatitis is the first presentation of some type of other gastrointestinal autoimmune disease. It doesn't have a large association with, systemic autoimmune diseases that you think about, like, let's say, lupus or diabetes, some of the other things you talk about. But I do always ask about family history of autoimmune disease when patients come in.
You said also earlier about triglycerides and about checking those. Is that more of an etiology from like a familial hypertriglyceridemia, or could those also be from like really uncontrolled diabetes?
Yeah, more frequently it's from a familial type of presentation, especially in our kiddo population. But we can see it with other etiologies of hypertriglyceridemia. If you have a hypertriglyceridemia that's, a couple hundred, above the upper limit of normal, you're not quite as worried. If you get into, the high hundreds or the thousands, that's when you're really worried that this could be an etiology.
So it sounds like, when we talk about etiologies, especially for the 16-year-old, we're thinking gallstone pancreatitis, we're thinking idiopathic, we're thinking medless. So and we're also thinking possible autoimmune. So generally speaking, we're getting trigs because they're easy, IgG4 because they're easy, but we're really going after the the CMP with the ultrasound, and then we're really doing a good med rec. We're just wondering
specifically in that patient, and trauma is one last thing to mention too. You want to make sure you have a history. Of, hey, did this kid fall off his bike 3 days ago and have a handlebar injury or something like that?
Yeah. And then, so I was wondering, actually, so this is seems classic for the 16-year-old. I kind of wanted to break it down a little bit by age and just see if something changes when you're younger. So for starters, what are the age groups that are most affected? Do we see this in much younger kids or babies?
Do, but not as frequently, especially when we're talking about just, acute pancreatitis. The differential definitely changes as you get younger. And you're thinking more about what are sort of some congenital things that might be causing this. If the patient has some sort of concurrent viral illness or something else is going on, we saw this during the COVID pandemic, patients with COVID are more predisposed to getting pancreatitis, or with, other sort of viral illnesses and things, then you probably are a little less inclined to do any sort of extensive workup. With those younger kids, I'm a little more inclined to potentially do more imaging workup if something doesn't add up. Usually, most of the time, we reserve more advanced imaging to those patients that are having recurrent episodes, more than one. But again, in that younger age group, I'm a little more inclined to do things like that because I'm thinking, does this patient have some of the things we mentioned earlier, colorectal cyst, a pancreas divissum? Is there something, odd going on with their anatomy?
And a similar question, in at the Cribsiders, we want to make sure that we're having discussions regarding disparities amongst different groups of patients. And I'm wondering if you know of any disparities that exist in different populations of people who are affected by pancreatitis. Are there certain people who, both incidence, prevalence, and then access to treatment?
Yeah, that's a great question. So from a standpoint of the incidence and prevalence, really there's not a big difference there. Now, when you start looking at management of pediatric acute pancreatitis, there's actually a great study that was published by Sinead Dike, who's at UAB, who we collaborate with her quite a bit on different research activities. She published a study looking at about 6,000 children diagnosed with acute pancreatitis over 6 or 7 years, and found that patients that were Hispanic or non-Hispanic Black children ended up getting a longer length of stay as compared to non-Hispanic white children, ended up having higher hospital costs, and then also it took a little bit longer for non-Hispanic Black children to receive opioids or IV fluids within the first 24 hours when you looked at that compared to non-Hispanic white children. So definitely some disparities that we need to address from a management standpoint and treatment standpoint.
Excellent. All right. I appreciate you answering those questions about sort of these different groups, and it's definitely very useful for our listening audience as well. So going back to our case, now that we have some labs, we have some imaging, one question I have that I vaguely remember from my med school days is when, especially with our adult patients, they always, I used to love to be, attendings used to love to pimp me on this thing called Ranson's criteria, which I know is used for adults. Do we have something similar for pediatrics, and are these types of severity scorings even useful in pediatrics?
That's a great question. So there have been quite a few articles published about this. The interesting thing is that we didn't have really a consensus definition of severe pancreatitis until about 4 or 5 years ago, when this was published from our pancreas committee through NASPGHAN, which is our Pediatric GI Society. And so a lot of these prior publications, which tried to make predictive scores or predictive labs to say, hey, who's going to be a more severe pancreatitis, just like Ranson's criteria does in adults. They were based on different criteria measuring what severe pancreatitis was. So one study might say, well, an ICU admission means severe pancreatitis. Another study may say it's related to having an acute renal injury, et cetera, et cetera. So we've actually had now for 5 to 6 years a more well-defined criteria for severe acute pancreatitis, where some of these studies have been able to look at things equally across the board. And we've done a couple of studies here at Cincinnati Children's actually looking at some basic lab and also some other labs that maybe you wouldn't frequently get in a clinical setting, trying to see what things might predict pancreatitis. One of the things that we found actually in a group of patients with acute pancreatitis was the blood urea nitrogen level, and that being higher than about 14 or 15 on presentation predisposed or sort of put patients in a category that they need to be monitored closely for potentially developing severe acute pancreatitis. We have also found that change in the BUN over the first 24 hours, how quickly it comes down, could also be indicative of that.
Now, is this the score that you're talking about? Is that the DeBento score or the pediatric acute pancreatic severity score? Is that the same thing?
Different.
So
none of those scores are really we don't use those typically in clinical practice in the pediatric world, just because none of them are well validated. And so, there are, various things to look at, but the quick and easy one that I frequently use is that blood urea nitrogen level.
Awesome. I think we should get into treatment. Is everyone okay moving on? Awesome. So treatment is one of the big things that that everyone wants to know here. So we're just taking this patient. We came in, we diagnosed her with acute pancreatitis. Let's kind of talk about treatment. First, let's kind of talk about treatment overall for acute pancreatitis of any etiology. And then second, we can talk about this etiology specifically.
Sure. So mainstays for somebody, treatment for somebody that comes in with acute pancreatitis, I think we're all pretty aware, this patient needs supportive care, IV fluids, pain medication. The main things, from a pediatric standpoint, when we look at patients that come in with acute pancreatitis, are making sure that, if the patient needs a fluid bolus based on their presentation, which I'd say, our patient here with a tachycardia, et cetera, could probably benefit from a fluid bolus. We'll typically give a saline bolus of 20 mLs per kilogram. And then we want to start them on IV fluids that are, greater than 1.5 maintenance for that patient. And typically we'll start them at about 1.5 maintenance total. And we'll put them on that IV fluid rate when they come in. And then, the other thing that we get asked questions a lot about is, what do we do with these patients? Do we make them NPO and not let them eat? Which historically, 15 years ago, patients with pancreatitis came in, and that was what we did. But really, if you look at all the modern literature in both pediatric and adult world, early patient-directed diet is the way to go in these patients. And so we start all our patients on a clear liquid diet, and we let them sort of advance themselves, and then pain control with an escalating type of pain control where we don't necessarily always start with opioids right away, but sometimes it's necessary based on the pain presentation of the patient.
Now I have a unfair question. So, like has been discussed before, we're all med peds. And a couple of years ago, back in 2022, New England Journal of Medicine had this trial that we now quote often in the adult literature in our management of pancreatitis. Some of us know as the waterfall trial. And in that trial, they really looked at fluid hydration versus less aggressive. Is there anything that could be generalized to pediatrics? Are anyone looking at possibly doing a similar type of study within our pediatric population?
Great question. So we've actually looked at this in our cohort retrospectively, and we haven't looked at it prospectively, but it's something we've talked about. The issue with doing these type of studies in pediatric patients is the incidence of acute pancreatitis in pediatric patients is not as high in adults. So doing a big study like that is a tall task to do it prospectively and get meaningful results. But when we looked at this retrospectively in our patients, what the waterfall study is really looking at is very, very high rates of fluid in adult patients versus sort of moderately high rates of fluid. And what they found is that the patients that got very, very high rates of fluid did not do any better clinically and ended up more frequently with fluid overload. And so they ended up staying in the hospital longer and having, more sort of complications with the fluid overload. And what we typically do in our patients and what our studies sort of showed was that if we cap the amount of fluids patients are going to get around 150 mLs per hour and we're not going up to 200 and 250 mLs per hour, even if patients from a weight standpoint could potentially take that. We leave them around that 1.5 maintenance with a max of 150 mLs per hour. Those patients tend to do quite a lot better than patients that get less IV fluids than that. And so we don't really have an arm of excessive, very, very high rates of fluid.
Yeah, that makes a lot of sense. I also have a question about the early enteral nutrition. I remember learning in med school that it has changed in the past 15, 20 years. And I'm wondering what the reason for that is. Like, what is the benefit of giving early enteral nutrition?
So I think we actually give the patients recovery much more quickly that way, because if we're withholding them from drinking and eating, if you can imagine, you're and this is really kind of conjecture. I don't think we have really, from a physiologic standpoint, any studies saying this definitively. But really, allowing the patients to have their own patient-directed diet, typically they eat more quickly than patients where we start them at NPO. They tend to have more support for recovery for their pancreatitis when we're looking at patients that start to get nutrition at an earlier time. Again, that's not anything that's published. It's not anything I think we know really well about, but there are plenty of studies that show that patients clinically do much better.
I think I've learned at some point, at least in adults, that the early enteral nutrition helps promote motility of the gut, but also decreases the translocation of bacteria and decreases the risk of infection. But I just remember learning that in the back of my head, and I don't have any studies to back it up either.
Yeah, I don't know that. I think there's a lot that we don't understand about the bacterial translocation and also the microbiome that goes on with acute pancreatitis. And that's like obviously the popular buzzword microbiome. There's a lot more to come on microbiome and pancreatitis. And there are studies going on in both children and adults with that. But I don't think we have anything now that we can conclusively say it's a major factor in the recovery. We may in the future figure something out.
So it sounds like the early mainstay of treatment is enteral nutrition, totally fine. Kind of start with, your classic, acetaminophen / ibuprofen. But if that doesn't work, opioids we kind of do for pain control, and then fluids we try to rehydrate off the bat for a bolus if you need to, followed by 1.5 maintenance up into about 150 cc's per hour. My biggest question, and this is kind of more to the physiology. We're doing all these things, but that's not like an anti-pancreas treatment. Why do we do the things we do, and what's our goal of giving these aggressive fluids?
Yeah, great question. So, really our goal here is what patients have is a systemic inflammatory response when this happens, right? So, they're doing a lot of third spacing, their intravascular volume is depleting. And if we don't replete that intravascular volume, what will happen is the patient will start to get other organs involved. And that's where we start thinking about more moderately severe pancreatitis when we find things like, acute renal injury, et cetera, that can be associated with, or multi-organ failure that can be associated with a severe pancreatitis episode. And so the goal of giving IV fluids, giving them quickly, is to really replete and maintain that intravascular volume to support the recovery process and support also good vascular flow to the other organs.
And does that change based on kind of presentation? So, for example, you came in day one. We talked about this with the amylase lipase question, right? You came in 30 minutes into your pain, trying to really reperfuse and make sure you're on top of things in the first 48 hours versus you came in day 5 and your pancreas already kind of did the things it was going to do. How does your fluid strategy change, if it changes at all?
Yeah, and really it's that within first 24 hours of admission and presentation that is the most important time. So am I going to necessarily change much of anything if somebody comes in towards the end? I might, but it's really going to depend on what their imaging shows. If they show a progressive necrotizing pancreatitis, we might approach things a little bit differently. Although we still do know, even in those patients with necrotizing pancreatitis, an early patient-directed diet can still work for some of them, depending on how bad their symptoms are. And we typically will start with IV fluids, but depending on their fluid status, and if they're coming in 5 or 6 days into their presentation and their pain, we may change the way that we're going to approach things a little bit. And I do want to mention, there are some adult studies out there and now some pediatric studies too, that lactated ringers as our resuscitation fluid may be a little bit more beneficial than using half normal saline or normal saline.
Awesome. And then just talking a little bit about any treatments to treat the underlying disease process with which we diagnosed our pancreatitis. Obviously, if it's idiopathic pancreatitis, there's not much we can do. If it's the drug, we try to remove the drug. But what about the other things like this case?
Sure. So this case, it's really going to be dependent on whether we feel like there's ongoing biliary obstruction or stones in the bile duct. If there are ongoing, there is ongoing biliary obstruction and or we think there's cholangitis, right? So if this patient has I don't know if we ever got our bilirubin results back, but let's say we did. And the bilirubin was 4.5 or 5, and our imaging shows a stone in the common bile duct. Well, if that's a persistent stone there, and or the patient has fevers, and we're worried about cholangitis, we've got to do a procedure to get that stone out and relieve that obstruction. And the procedure that we do for that is an ERCP, where we go in with a scope and we try to relieve that stone obstruction. So that would be one treatment that we would potentially need to do in a patient like this.
In a patient who has cholecystitis, I would imagine that would be an indication for most likely an elective cholecystectomy, which may be getting out of the wheelhouse of this discussion. But
yeah, no, great question. So we actually recommend, and all our guidelines recommend now, if a patient comes in with gallstone pancreatitis, they should have their gallbladder taken out during that admission. They are at risk if we discharge these patients and say, hey, come back in a month and get an elective cholecystectomy. They're at risk for another episode of gallstone pancreatitis. So any of the patients, even if we end up needing to do an ERCP and relieve an obstruction in the common bile duct, the patients should have a same admission cholecystectomy to prevent morbidity down the road with another stone causing a problem.
Great. That's a great takeaway. From a general pediatrician perspective, because I would imagine a lot of our listeners are probably going to be the pediatricians who are following up on these patients after they're discharged from the hospital, are there any complications of acute pancreatitis that we should be on the lookout for?
Sure. I mean, if we have a patient that has acute pancreatitis and then they end up with persistent pain or persistent issues as an outpatient when they go to follow up, we definitely want to keep in mind that we can have things occur down the road like necrotizing pancreatitis, where basically, some part of the pancreas turns into, a necrosis and ends up turning into sometimes even a fluid collection that needs to be drained, and they can be quite large. The other thing that can happen are pseudocysts, which is the same sort of idea, except that it doesn't have any internal debris like a necrotic collection might have. Those are relatively rare complications, especially in patients that sort of present with a milder course and do well and leave the hospital. But we do know that patients with gallstone pancreatitis are more likely to get those type of complications.
And I got two more questions about kind of complications. The first one is, how many patients end up with exocrine dysfunction after they leave?
Yeah, so that's a great question. With acute pancreatitis, the number is very, very low. The biggest risk factor for that would be in these patients who maybe have a necrotizing type of episode of pancreatitis. And what happens in necrosis is part of the pancreas gets broken down and it's gone. So, sometimes I'll see a patient who had a gallstone necrotizing pancreatitis and the body and tail of their pancreas on their imaging is no longer there. So those patients are definitely at higher risk for developing exocrine insufficiency down the road. If you are talking about a patient that comes in with an acute pancreatitis because they have a concurrent virus or they're on a medication that then gets stopped and they do relatively well and leave the hospital in a few days, the odds of getting exocrine pancreas insufficiency from that are exceptionally low.
And the other question is, actually, I'm actually going to take this because this is a good follow-up question. If you actually have acute pancreatitis, are you going to follow everyone up in, say, 3 to 6 months and repeat imaging and maybe do exocrine and endocrine function? Or unless they have persistent pain, you're not going to see them and you feel like we're good?
So historically, it's been the latter. Historically, we've said, yeah, no big deal. You're going to hopefully be in that 70% of patients that don't get another episode. If you do get another episode, come follow up with me as your pediatric pancreatologist. Well, more recently, I think I mentioned this earlier, we've looked in a couple studies with some nutrition deficiencies, some issues with insulin response, et cetera, A1Cs in patients that have just had a single episode of pancreatitis. And it's not super well understood just yet. But what we're doing at our pancreas center here now at Cincinnati Children's is we are following up all patients with acute pancreatitis at 3 months, at 12 months after their episode of pancreatitis to check those labs, check in on how they're doing. If we look at even just symptoms from those patients, about 50% of patients have some sort of lingering abdominal pain through that first year after an acute pancreatitis episode, even the ones that don't go on to develop recurrent pancreatitis.
And that workup at that time, say with a 3-month visit, do you automatically get A1C? Do you automatically get pancreas elastase? Do you automatically get cross-sectional imaging, or are those all case dependent?
I do at this point as a routine, just based off some of the studies that we've done here. But I would say, probably, and we have a big pancreas center here. We see lots and lots of patients, and do quite a bit of clinical and basic research here. And I think, if you asked a lot of pancreatologists around the country, not everybody would be following that, but we do follow that here just based off some of the data that we've got here and are actually soon to be publishing.
Awesome. And I just named a couple of them. Are there anything else that I missed other than those 3 tests?
Well, we do get some other nutrition labs, so we'll get fat soluble vitamin levels, ADE, and also get an INR as a surrogate for vitamin K. I think those are really important to get at those follow-ups.
Awesome. And then I have one last complication of pancreatitis that I want to talk about. Sorry, everybody. I've kind of overtook this over here. The kind of infection component. So the kid that's fevering, the kid that's still having abdominal pain, when during those cases do you repeat cross-sectional imaging and or start antibiotics in those kids?
Great question. So I base it a lot on clinical symptoms. If the patient is not getting better over the course of a couple of days, they're really not turning the corner with their PO intake, that would probably be a patient where I say, hey, the transabdominal ultrasound looked pretty good when we got them in here. It just looks like, pancreatitis, but we probably need to get some follow-up imaging to see if they're developing necrotizing pancreatitis or a fluid collection. The patients that that may be having recurrent fevers, same thing. We probably want to get some imaging to see how the pancreas is looking and how things are evolving. Now, that being said, a lot of times we are looking at these patients, they're getting recurrent fevers, but they don't have any infection, even when they have a necrotizing pancreatitis. That in and of itself, and the body's reaction to the pancreatitis can cause fevers in the absence of infection. And so we're pretty careful about trying not to just flood these patients with antibiotics, and pretty selective about who we put on antibiotics when they have, usually we kind of reserve that for patients that actually have signs of infection on imaging.
And so it has to be on imaging. So you see an abscess or something like that. Is that what you're saying?
Right. If they have a necrotizing pancreatitis or collection that has some air in it or air bubbles in it, or, hyper enhancing rim, those type of things, we might definitely start, antibiotics. Or if the patient's extremely sick, right? So there's, a patient who's sitting on the floor and spiking low grade fevers every once a day, versus a patient that's, spiking fevers to 40 and is now transferred to the ICU and is getting septic. And then obviously, you're in a different story there.
Awesome. So sorry, I split that as a complication. So for everybody, it sounds like from a inpatient perspective, if you're still in the hospital, still fighting fevers, we really would probably repeat cross-sectional imaging, but at that point you wouldn't necessarily start antibiotics unless you were hemodynamically unstable and or we saw signs on imaging itself. But as an outpatient, if you made it home without a problem, fantastic. It sounds like we're getting a little bit more data to say, hey, maybe at that 3-month mark, maybe we should check how functional your pancreas really is from both an exocrine and an endocrine function. You're recommending A1C, ADEK, and fecal elastase, and then as well as repeat cross-sectional imaging, which I imagine would be whatever your initial modality would be. Would that be correct?
Yeah, well, and that 3 and 12-month follow-up, if they're doing well, we don't get any repeat imaging.
Oh, okay.
So we typically would not follow up with any imaging, really just check in, have a clinic visit, see what some of those labs look like, and make sure that we don't have any deficiencies. We've seen a pretty substantial, low vitamin D levels in these patients at 3 and 12 months post pancreatitis.
Cool. Yeah, we could definitely do that in our clinic at 3 months. I'm all about that.
I really want to thank you for the amount of time you spent with us tonight. I think as we wrap up our discussion here on acute pancreatitis, I want to ask if there's anything else you want to let our listening audience know about. Otherwise, maybe I'll ask you for some take-home points about acute pancreatitis.
Sure. I think, and probably nothing else we need to touch on, but I think the main take-home points are what we really are looking for when a patient comes in with acute pancreatitis are a few things. So number one, we want to look for any reversible causes of pancreatitis, right? So is this patient on a medication that has caused pancreatitis? I always harp on that with my residents and fellows. look through the medication list, make sure there's nothing that was recently started. Reversible cause is in this patient, with gallstone pancreatitis. We don't want to have a patient with gallstone pancreatitis and send them out and send them home for them to come back in a couple of weeks with a similar kind of presentation. We want to make sure that those reversible causes, if they exist, are taken care of. Triglycerides we talked about as well. And then I think the other thing, from a management perspective, the take-home points are these patients need IV fluid resuscitation as quickly as you possibly can. And that definitely will modify their outcomes. If you get good IV fluid resuscitation, if they're under resuscitated, they do have more of a chance to end up with complications or end up in ICU. Early patient-directed nutrition is really the way to go for these patients based on some good data.
Excellent. Well, thank you so much for talking with us tonight. I'm going to encourage our listening audience to come back for our next episode. We're going to talk about chronic pancreatitis with the group here. So come back.
The number you have dialed has been changed. The new number is...
This has been another episode of the Cribsiders.
It's for the kids!
For the kids!
Get show notes and sign up for our weekly Knowledge Food Formula Feeds newsletter on our website at www.thecribsiders.com.
We're committed to providing you with high-value, practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts, or contact us at thecribsiders@gmail.com. A special thanks to our producer, Rachel Holloway, and our wonderful social media team on Twitter and Instagram. I've been Sam Mazer.
I've been Rachel Holloway.
And this has been Chris the Chew Man Chew. Thank you and good night. And if you made it to the end, here is a poem written by AI. The Pancreas Parade. There's a party in your tummy, but your pancreas is inflamed. We'll do some tests to figure out why it's angry and untamed. First, we'll draw some blood samples, check amylase and lipase too. Then a special tummy picture called ultrasound. It won't hurt you. The IV in your arm, my dear, brings fluids clear and bright. It helps your body heal itself and makes everything all right. We'll start you on some gentle foods, small amounts, but don't you worry. It helps your tummy heal up fast. No need to wait or hurry. For pain, we've got some medicine to make you feel okay. We'll keep you comfy and relaxed as we check on you each day. We'll monitor your vital signs, temperature, heart rate, and more, making sure you're safe and stable. That's what doctors are for. Rest up now, little patient. Let the treatments do their thing. Soon you'll be back to playing and your pancreas will sing. For now, it's monitors beeping and nurses checking in. When your pancreas calms down at last, we'll all share a great big grin. See you guys.